Welcome to PT 771. In this presentation, we'll discuss measurement concepts including reliability, validity, and other related issues regarding measurement and diagnostic accuracy in physical therapy. In this presentation, we'll discuss the psychometric properties of different measurement tools that we use in physical therapy, including reliability, validity, and change, or the clinical meaningfulness of a measure. Take a moment and review some of the different components of each of these characteristics before proceeding forward, and we'll discuss these different characteristics on the slides that follow. Let's begin by discussing the concept of test-retest reliability. And this really relates to the reliability or how stable an instrument is over a period of time, assuming that the population that you're evaluating has not changed. And this is a very important quality because we want to ensure that the instruments we use in physical therapy as well as the tests and measures are truly reliable, meaning that if I use an instrument on day one and I reassess that patient with that same instrument in 2 weeks, I want to make sure that if the patient has not changed, that those scores are relatively close. They should be very similar, and that really speaks to the reliability of an instrument. And so some questions that come up is that how long should the test and retest interval be when we're evaluating reliability? And I would say that I think a good question along the lines of that too is, what type of measurement are you going to use in the clinic? When will this patient be evaluated, and when will their reevaluation be to determine outcome and if the patient's improved? Many times that could be a week or 2 weeks. In some populations, it could be a few weeks or even several months to determine whether or not the patient's improved. And so when we evaluate the test-retest reliability or stability of a measure, we want to take that into account. Also, are the intervals far enough apart to minimize carryover? And what that would mean is that, let's say we're looking at outcome on a paper and pencil test that assesses physical function through a series of questions that a patient would complete. Hopefully, when we evaluate the test-retest reliability of that instrument, number one, the patient population is stable, but number two, we minimize the opportunity for the patient to recall what answers they put on the first instrument. And so we would want there to be some time to allow that recall to subside so we're truly getting an accurate measure of the patient's physical condition. This could also take place, carryover would also be a concern if we're looking at measures of physical function, let's say hop testing in patients following ACL reconstruction. If we test individuals too close, there likely could be some carryover just from simple motor learning and practice. And so we want to separate those test sessions far enough to really minimize those effects. And so again, from a test-retest reliability perspective, this really looks at how stable an instrument is over time. And hopefully those scores are going to be extremely close if the instrument is strong from a reliability perspective. While test-retest reliability looks at the stability of an individual instrument or measure, another component of reliability deals with reliability amongst different testers or raters. And the first one we'll discuss will be inter-rater reliability. And that looks at the degree of agreement among different raters for a particular test. So on the right there, we see a physical therapist taking range of motion measurements of the knee. Inter-rater reliability would refer to how likely is it that a group of 2 or 3 physical therapists would have measures that are relatively close in measuring knee range of motion for a patient. Intra-rater reliability looks at the degree of agreement among repeated administrations of a test performed by a single rater. So this could also be in terms of what we talked about in terms of test-retest reliability. So again, the physical therapist taking measurements of knee range of motion at the knee, how likely is it that their measures on day 1 will be consistent with their measures on day 14 if the patient's status has not changed? These are 2 very important components of reliability. Inter-rater reliability, especially if you're working in a clinic where many different physical therapists may be interacting with the same patient. We want to ensure that those measures obtained by different clinicians are stable, especially in a population that's not changing over time. Another psychometric property that we commonly see in rehabilitation research that's assessed is the amount of change that we potentially see in a test or measure or an outcome score, and whether or not those scores are clinically significant. We know that even individuals who potentially have statistical significance with a particular test or measure or outcome score, that can be dependent on several different components, like sample size and standard deviation. And so we could potentially see statistically significant changes that may not necessarily be deemed as clinically important. And so how do we determine if a measure is clinically important? Well, we would start by determining what the minimal detectable change is in a measure. And this really indicates the amount of change required to exceed measurement variability. And we derive this particular measure almost in a means of looking at a test-retest reliability. We're taking a stable sample and we're looking at two different points in time, and we're determining what amount of change is necessary to exceed that anticipated measurement error and variability. So if you look at the part of this figure at the top of the page, you see that we have on the left there, along that continuum, no change. And there's a point where change is going to be due to anticipated measurement area variability, but the change really will not matter much to a point of exceeding that variability, and certainly won't matter to a patient. And so the minimal detectable change really is the change that we see, that we begin to see measurement variability and error exceeded. There's also going to be a range in there where we're likely going to see change again, but it may not be meaningful to the patient. It may exceed measurement error and variability, but again, it won't be deemed as being important by the patient. And so when we understand that a clinical change is occurring in a particular measure, we know that we've exceeded the minimal clinically important difference because now the patient tells us that this change is meaningful to them. And that minimal clinically important difference really indicates the amount of change required to produce clinical meaningful change. And again, we estimate this in a patient population who's expected to change over time and try to determine whether or not their outcome is now positive. And so again, there's a continuum of change that we'll see in our physical therapy patients. The minimal detectable change is that amount of change we need to exceed measurement variability, while the minimal clinically important difference is what we need to really begin to determine whether or not the changes are clinically meaningful to a patient. So the Oswester Disability Index is a common measure of physical function that we see utilized to evaluate outcome in patients with low back pain. It really evaluates 10 different areas related to pain, ADLs, and physical function, and it's scored on a scale of 0 to 100. And so higher scores mean lower levels of ability. And so what is the minimal detectable change that we need to see to exceed measurement error in this particular survey? It's about 10 points. And so if we have a patient who scores a 50 initially on the survey, which indicates a moderate to high level of disability, we know that we need to see at least a change of 10 points just to exceed measurement error and variability. Well, what would constitute the minimal clinically important difference for a patient? Many studies now look at a change of about 50% or more in the survey to determine a minimal clinically important difference, meaning that those are changes that are clinically meaningful to a patient. So for example, if we have a patient who scores a 50 at the time of intake, we would want to see a change of about 50% or a score 25 or below on the instrument to know that the patient has now exceeded that minimal clinically important difference. Again, there's a lot of variability in the literature in terms of what constitutes the MDC or the MCID, but those are two examples that we've given you here with respect to this one instrument that can help you determine if the changes you see have exceeded measurement error and if the changes that we see are clinically important to the patient. Let's switch our focus now to discussing different types of validity. And two types of validity that are really important are face validity and content validity. And so face validity, which is really the lowest form of validity, looks at whether or not a test really evaluates what it says it's going to test. And so, for example, we could design a survey that looks at patient satisfaction following a course of physical therapy intervention. And we could develop that survey and send it off to some individuals who are experts in survey development, and they may send it back to us and say that the questions appear to be relevant and they appear to be related to important concepts of patient satisfaction. Thus, we might conclude that that survey at the very least is valid on its face. Content validity really evaluates whether or not the survey measures and is a complete representation of the concept of interest. Does it really sample the entire universe of content related to that particular topic area? So going back to our survey that we developed, it's going to evaluate patient satisfaction in patients who've completed a course of physical therapy intervention. We may want to know, does the survey appear to be valid in terms of content? Have we truly sampled all the areas of interest that relate back to patient satisfaction? Again, these are two basic forms of validity that are really important to establish before moving forward to look at higher forms of validity assessment. Another form of validity relates to criterion-related validity, and this relates to whether or not you can use a new test as a substitute measure for another one. And the first component of criterion-related validity relates to concurrent validity, and this really looks at how well a new test that we've developed compares to a well-established test. So for example, we may develop an app for our iPhone that really helps us evaluate range of motion of, say, the knee and the shoulder. Before we would go forward with that particular measure, we would want to determine how well does that application compare to a well-established test like standard goniometry or using an inclinometer to evaluate range of motion. And we want to determine whether or not concurrent validity is established with this new test before we move forward. Again, we would compare those measures to a well-established test prior to moving forward. Another component of criterion-related validity relates to predictive validity, and this relates to how well a certain measure can predict certain behavior in the future. And so if we look at standardized educational assessment measures like the ACT or the SAT, how well do those scores actually predict educational success? Take it back to a physical therapy example, predictive validity relates to, let's say, how well hop testing following ACL reconstruction really helps us understand if an individual is able to return to sport following ACL reconstruction. So for example, we know that with a series of hop tests, we usually want at least 90% performance of the involved side to the non-involved side before we can allow that individual to return to some sporting activities. Now that one measure may be used with other measures of predictive validity, but at the very least, again, that measure of predictive validity of hop testing really refers to how likely is it that given a particular score on that test, that patient is now going to be allowed to return to sport and likely be successful with a low risk of re-injury. In addition to some of the different types of validity that we already discussed, other forms of validity relate to clinical diagnostic tests and accuracy, including sensitivity, specificity, and likelihood ratios, and we'll cover these concepts on the slides to follow. So on this slide, we provide a table for you from a paper published by Julie Fritz and Rob Weiner titled Examining Diagnostic Tests, an Evidence-Based Perspective. And in this particular paper, they went ahead and they summarized the diagnostic accuracy statistics for several different special tests related to the shoulder that are useful for diagnosing subacromial impingement syndrome. So before we move forward, just take a moment and review the numbers on this particular slide in terms of sensitivity, specificity, and likelihood ratios. And we'll discuss this again at the end of the presentation, but see if you can make any sense of some of the data here and how some of the data here might inform your examination and management of patients who potentially have subacromial impingement syndrome. So on the last slide, we provided a great deal of data for you in terms of sensitivity, specificity, and likelihood ratios related to different tests that are helpful in diagnosing subacromial impingement syndrome. And why should we be concerned with that type of data related to the accuracy of clinical diagnostic tests? First and foremost, it really is an important step in the move towards evidence-based practice, which really provides the best care for our patients. Understanding that a type of information is critical in establishing an accurate diagnosis and determining appropriate treatment. And it's important in helping patients understand their prognosis, because those type of tests and measures really help us hone in on a proper diagnosis again and the appropriate treatment for our patients. Let's take a moment and discuss these basic concepts of sensitivity and specificity. The formal definition of sensitivity is the portion of the population with the target disorder and a positive test. The formal definition for specificity is the portion of the population without the target disorder who have a negative test. And so when we look at those definitions and we think, well, how can this really help us inform our practice? It's important to note that tests with high sensitivity that have a negative result help us rule out the condition. And we can use the acronym SNOUT for that. With regard to specificity, tests with high specificity that have a positive result help rule in the condition. And we can use the acronym SPIN for that. And so we're dichotomizing whether or not a test is sensitive or specific, or potentially both. And for the purposes of our discussion here today, we're going to use a cut point of 80% to discuss whether a test is sensitive or specific or not. Because again, we're dichotomizing whether a test is sensitive or specific or not, because if a test is sensitive or specific, it does help us either rule in or rule out a condition based upon the results of that test. And we'll use a number of 80% for our discussion as we move further. So in terms of whether or not tests are sensitive or specific or not, let's first talk about tests that have high degrees of sensitivity in this particular table. So the Hawken and near and horizontal adduction tests have the highest degrees of sensitivity, meaning if those tests are negative, we can rule out subacromial impingement syndrome. In terms of specificity, the drop arm, the painful arc, and the Yergeson tests, those tests are highly specific, meaning that if that test is positive, it's helpful in ruling in the disorder. So again, take a moment and look at those specificity and sensitivity numbers and be sure that you understand the significance of those. Again, tests that are highly sensitive, if they're negative, they help rule out a disorder, but if they're positive, they help rule a disorder in. And there are several different tests that we learn in orthopedic medicine to help diagnose different orthopedic conditions, but the sensitivity and specificity really help us understand the importance of those from a clinical perspective. When we described sensitivity and specificity, we described dichotomizing test results to determine whether or not clinical conditions are present or not based upon that cut point of 80%. And so sometimes that's very helpful, but sometimes we know that we would rather quantify the probability for a condition, whether or not it exists. And that may be a bit more pragmatic for some of the clinical conditions that we treat. And so we can use the measures of sensitivity and specificity. We can combine those to form likelihood ratios and calculate these. And the likelihood ratios really allow us to quantify shifts in probability for a condition. Understanding sensitivity and specificity data allow us to calculate positive and negative likelihood ratios. In a positive likelihood ratio, really expresses the change in odds favoring disorder given a positive test. And the higher a positive likelihood ratio, the more certain you can be that a positive test indicates the person has a disorder. And the formula for that is sensitivity divided by 1 minus the specificity. A negative likelihood ratio expresses the change in odds favoring the disorder given a negative test. So the lower the negative likelihood ratio, the more certain you can be that a negative test indicates the person does not have the disorder. And the formula for this is 1 minus sensitivity divided by the specificity. And so again, positive and negative likelihood ratios are important because they allow you to quantify shifts in probability given a positive or negative test result. And a positive likelihood ratio most likely goes with tests that are highly specific. So tests that are more specific, you'll see higher positive likelihood ratios. And with regard to negative likelihood ratios, this will align with tests that have higher degrees of sensitivity. So tests that have higher degrees of sensitivity, you'll see lower negative likelihood ratios, which again allows you to express the change in odds favoring a disorder giving a negative test. So I think these are helpful because when used in combination with sensitivity and specificity, they're very powerful in helping us determine really whether or not a clinical condition exists or not. And so this table is important because it really provides the data for how we would interpret positive or negative likelihood ratios. Let's first look at positive likelihood ratios on the far left there. And so if we're dealing with likelihood ratios, positive likelihood ratios of 1 to 2, it really alters probability to a small and rarely important degree. Positive likelihood ratios between 2 and 5 generate small but sometimes clinically important shifts in probability. And to be perfectly frank, many of the tests and measures we utilize in physical therapy have positive likelihood ratios in that range of 2 to 5. So we will definitely see tests and measures with those positive likelihood ratios, and we sometimes have to make a decision as to how that may shift our probability. Positive likelihood ratios between 5 and 10, those are something we need to take considered seriously because they do generate moderate shifts in probability. And then likelihood ratios greater than 10, these are gold standard type tests that generate large and often conclusive shifts in probability. If we look at negative likelihood ratios, the smaller these are, the better. And the closer they are to 1, the more likely they are that there isn't really a significant shift in probability. And so negative likelihood ratios less than 0.1, those are equivalent to positive likelihood ratios greater than 10, that they generate large and often conclusive shifts in probability. Negative likelihood ratios between 0.1 and 0.2, these generate significant moderate shifts in probability. And again, when we see negative likelihood ratios in that range, we need to take those into consideration because we're shifting probability towards the fact that a condition likely doesn't exist. Negative likelihood ratios between 0.2 and 0.5, these generate small but sometimes important shifts in probability. Again, many of the tests and measures that we see in physical therapy are within that range. And then if we see negative likelihood ratios as they approach 1, anything between 0.5 and 1, they alter probability to a small and really a rarely important degree. So again, take a moment, study the positive and negative likelihood ratios on this slide before moving forward to the data slide on the next page. So now that we've discussed sensitivity, specificity, and likelihood ratios, let's go back to this data table here and see if we can try and make some sense of some of the findings here. And so again, if we look at the tests that are most sensitive, the Hawken, the near, horizontal A deduction, those are the tests that have that above 80% cut point. We also determined that those tests are not very specific. And if you look at the positive and negative likelihood ratios, again, the positive likelihood ratios are awfully close to 1, but the negative likelihood ratios, right, at least for Hawken and near, right, those likely have some clinical significance, right? Those may provide data for us that are relatively clinically important in terms of a negative test. And so in this particular case, the Hawken and Neer are probably most helpful in helping us rule out shoulder pathology in terms of a negative test. However, Hawken and Neer are typically taught as tests to diagnose shoulder impingement syndrome, yet they're not specific at all. And so to use Hawken and Neer as tests, if they're positive, to help rule in pathology really is not supported by the data. And so how would we use potentially Hawken and Neer in this particular scenario? Well, let's say we have a patient who has upper quarter type symptoms, and we're not sure if they're related to the neck or the shoulder. Well, if we examine the neck and we determine that some of the symptoms are provoked through examination of the neck, we know we want to assess joints above and below those primary areas of symptoms. And so if we evaluate the shoulder, we could look at maybe range of motion. Let's say that doesn't necessarily change symptoms at all. We can apply overpressure, no change in symptoms at all. We can look at strength, and strength looks really good, 5 out of 5 and pain-free. If we want to really put the icing on the cake and really rule the shoulder out, we would use Hawken and Neer and potentially horizontal adduction to assist us if these tests are negative in ruling out shoulder pathology in that patient who has upper quarter symptoms. And let's say that we know that the neck is a symptom generator, shoulder tests are completely negative, Hawken and Neer are negative as well. So that really helps us rule out shoulder pathology. It's not something we're going to be concerned about early on in the course of care. Let's flip the switch a little bit though. If we take a look at specificity, let's say we're dealing with a patient who now has primary shoulder problems and we're trying to diagnose rotator cuff involvement and subacromial impingement syndrome. We wouldn't necessarily use Hawken, Neer, or horizontal adduction or even Speed's test, because a positive test in that regard does not necessarily give us information because the test is not specific. However, a positive drop arm, we know that if a positive drop arm is present, that's highly specific for rotator cuff tearing and pathology. And a painful arc and Jurgensen also are highly specific as well. And if we move over to the positive likelihood ratios there, we see that there may be some utility with respect to Jurgensen as well as drop arm. We're beginning to get above that 2 point, close to 3, where there may be some clinical significance associated with those. So nonetheless, using sensitivity as well as likelihood ratios, it really helps us determine whether or not our tests and measures, given a positive or negative result, really help us rule in or rule out pathology. Again, in this regard, Hawken and Neer are probably best used if they're negative to help rule out pathology, while with respect to specificity, the Jurgensen, the painful arc and drop arm test, and the positive likelihood ratios correlate to that as well, really help us rule in pathology if those tests are positive while the other ones do not. So for the content relating to sensitivity, specificity, and likelihood ratios, we've included a paper for you that provides some additional information on these concepts. The author of the paper is Megan Davidson, and I think the paper really does a nice job of explaining these concepts and providing some nice clinical examples for you that I think will assist with your understanding of these important concepts. This concludes our presentation. Thank you for your time and attention.